Welcome, my dear friends, for a fabulous evening. I feel proud to represent CCA on this August virtual meeting. Few weeks back, we were really, thinking, we means our office bearers were really thinking of what are the webinars that we must do to maintain the enthusiasm and quality and high standards in the upcoming CCA webinars. When we were thinking, our beloved chairman, Dr. N.H. Krishna, has suggested a brilliant idea that why can't we do masterclass sessions? Yes, with this brilliant suggestion, we have took masterclass series from today onwards. Next few weeks, we will be having back-to-back masterclass sessions and on various interesting topics in pulmonology. So at this outset, I profusely thank our CCA office bearers, in particular Dr. N.H. Krishna, Dr. Ravi Doshi, Dr. Narayan Pradeepa, Dr. Narendra and Dr. Atri Gangopadhyaya for their relentless hard work and commitment in maintaining the back-to-back quality webinars for the CCA members and Indian pulmonology. At this outset, I welcome Professor Chabra sir. I'm sure Chabra sir doesn't require any introduction to any pulmonologist in the subcontinent. He is treated as a Adiguru or Dronacharya of Indian pulmonology. Sir is currently working as a professor and head of the department of pulmonary critical care and sleep medicine at Primus Super Specialty Hospital, New Delhi. He was former director for VPCA. I welcome you, sir, and we are looking forward for a brilliant talk from you. This will be treated as a Bhagavad Gita on spirometry. Looking forward for you, sir. Thank you.
Good evening, ladies and gentlemen. Today we are going to discuss spirometry. Now, spirometry is a very useful lung function test, and in chest medicine, it is one of the most important diagnostic tools that we have got. All residents in chest medicine must know spirometry so that when they graduate and go into practice, they are able to use it properly. So I'll be touching upon the basics of spirometry, about the instrumentation, what is the procedure, and how to interpret it. Now, when we do spirometry, then we measure certain physical parameters. We measure volume, we measure time, flow. Then there's another physiological measurement, pressure, which is not relevant in spirometry. But when we use a body box, then pressure measurements are made. So these physical measurements are made in lung physiology, in lung function testing, as well as in critical care medicine. So in spirometry, it's the measurement of volume, time, and flow, which is used during a breathing maneuver, and we make our interpretations. Now, what is spirometry? Spirometry is a medical test that measures the volume of air an individual inhales or exhales as a function of time, which means that we are measuring how much air is going in or out over how much time. So basically, two terms are employed here. One is a measurement of volume, the other is a measurement of time. Now, this is how spirometry was done initially, more than 100 years ago, when Hutchinson first invented the spirometer. In modern laboratories, what we actually measure is volume against flow. So this transition from volume versus time to volume versus flow, I'll be touching upon later in subsequent slides. But at this junction, it is sufficient to understand that although spirometry is a measurement of volume versus time, what we generally express now is volume plotted against flow. And typically we get what is known as a maximal expiratory flow volume curve, or MEFV curve. So this printout is something like you get ECG in a cardiology workup. So this is the printout that is obtained in spirometry machines, volume versus flow. Now, spirometry is one of the most useful lung function tests. When we say PFT, then we mean a lot of lung function tests, including lung volumes, diffusion capacity. Now, these tests measure specific functions of lung. Among all of these, spirometry is most informative because it is affected by disease of airways, disease of parenchyma, chest wall, even cardiac dysfunction. So one test gives a lot of information about where a possible pathology may lie. It is a little bit difficult to do because the subject has to be very well trained to do the maneuver. And generally, it is not possible to train a subject who is less than 6 years of age. Above 6 years, we can train a person to do spirometry. It is very well standardized and reproducible. Now, these are two very important attributes of any test that we do in medicine. The standardization is that we use the same protocols, same measurement procedures technically, so that we get the same kind of measurements and we are able to compare the studies as well as use it in research. So the first standardization was made in the Snowbird workshop, that was in 1987. After that, in 1995, then 2005, and most recently in 2019, these statements have been revised, although the essence of spirometry remains the same. And these are changes with technology. So that today's spirometers, they are computerized, very small, and they do very accurate measurements. Then the parameters that we measure in spirometry are very, very reproducible, which means that if we do spirometry again and again, we'll get practically the same kinds of values. So it is a very reliable test. Technically, spirometry is very challenging, and this is where the role of the technician and the role of the person who is supervising the test that comes in. The quality control of spirometry cannot be overemphasized. You can get totally inaccurate results if spirometry is not done properly. It's not a question of just blowing into the machine, but it's a question of doing it properly. And there are several aspects to the quality control which the technician as well as the person in charge of the lab must exercise. First begins with the purchase of the equipment. There are different kinds of spirometers available in the market. The one that you should go in for should be meeting the specifications of American Thoracic Society and European Respiratory Society. Now, these technical specifications are laid out, and your equipment must perform according to these specifications. And usually the manufacturer will give a certificate that this is as per the specifications. Then how to maintain the equipment is important. Every day before the testing is done, the machine has to be calibrated. And the calibration has to be verified during the day, because calibration can easily go wrong. And once calibration is wrong, then the results are wrong. If the calibration is inaccurate, then you might be measuring a vital capacity of 2 liters as 2.5 liters. Technician has to be very well trained, both in the calibration and maintenance of the equipment, as well as teach the patient how to do the maneuver. The technician must understand the physiology of the maneuver, what is the correct maneuver, what are the errors, so that he can pick up whether the patient has done it properly or not, or whether the patient needs to do it again. The patient has to do it properly, and he may require coaching, because when the patient does it for the first time, then he has no knowledge of how to do the procedure. The technician trains him. Now, the maneuver itself is not a physiological maneuver. The maneuver is totally different from what we breathe normally, the way we breathe normally. So, coaching of patient is important. Finally, the physician has a very important role in overall management of the laboratory. He has to oversee that the technical maintenance of the equipment is done properly, the technician is trained properly, patients are handled properly, and finally, once the results are obtained, how to interpret those results. So it's a quality control throughout the procedure, right from procuring the equipment to maintaining it to doing the test and interpretation. So spirometry is easy. It looks apparently easy because these days with everything computerized, you get the signals, you start breathing, you stop the breathing, and you get a printout. But that printout, one can say, is garbage in, garbage out if it is not done properly. So spirometry is easy, but good spirometry is difficult. Now there are two kinds of equipments. One are the flow measuring devices. These are called pneumotacs. Pneumo means air, tac means rate. Then there are volume measuring devices. Now flow measuring devices measure flow, and from the flow by integration, that is electronic integration, we measure the volume. In volume measuring devices, we measure volume and we differentiate the signal to get flow. So actually we are recording one signal directly and getting the other by derivation. So these signals, flow and volume and time, these can be displayed in two ways. See, our display is X versus Y or on two axes. So either it can be volume versus time or flow versus volume. Each has its plus points, and in normal functioning, we obtain both the tracings or both the printouts from the same maneuver. So the patient need not do it twice, but our equipments, they are made in such a way that they will give you both volume time and flow volume curves in the same maneuver. Now these are some of the flow spirometers. Now this handle here, this is a flow meter. So here the patient breathes. This has electronic circuitry. So this signal is converted into electronic signals, and then that is measured in the computerized equipment. So there are different kinds of pneumotacs available. Now these are very compact, lightweight equipments. So they can be taken in your briefcase and you can do it in the field as well as on the bedside. All you need is a PC and just plug it into the USB port and one is ready to do spirometry. These are bigger machines. Now this machine, this is a complete lung function machine. So this has provision for diffusion capacity, lung volumes, and this box here, this is the volume spirometer. That is, the person breathes into this, so this piston will move. So it collects the air that the person is breathing into it, and person breathes from this. So this becomes a closed circuit. So patient is breathing in and out, and how much he breathes in, we measure by the displacement of the drum, which is inside this. So this is a volume spirometer. Normally volume spirometers are big, bulky, but they are more sturdy and they maintain their calibration for long. These used to be very popular once upon a time, but gradually we have shifted over to flow measuring devices. Then the other things that are required in doing spirometry are mouthpieces. These mouthpieces may be disposable or reusable, which can be autoclaved. Now this one on the left, this is a silicone rubber mouthpiece. So this has got this thin plate. So this comes between the lips and the gums, and this gives a tight seal. So the teeth will come on these processes here. But it is very important that when the person is breathing, then there is no leak around the mouth. So tight fitting mouthpieces are highly desirable. Now these ones are plastic or even cardboard mouthpieces are available. There may be a problem of tight fitting, but these are disposable, and that is the advantage of these mouthpieces. Then nose clips. The maneuver is done by mouth breathing. So the nose has to be blocked by these sponged nose clips, which gently press the nostrils so that the person's nose is blocked. Then calibration syringes. These are very vital in maintaining the equipment. Each time you start the machine, you have to calibrate. Now these are of different sizes. This is 3-liter syringe. This is a 1-liter syringe. So calibration means that you push in 1 liter or 3 liters of air into the machine, it measures 3 liters. So once it is doing that correctly, or the machine will correct the error if it is there. So that once the patient does it, then there is no error in measurement. So this is very important, and any equipment that you buy, you should always buy a calibration syringe, although it will cost a few thousands more. But maintenance of equipment requires a calibration syringe. Then you require filters. Now filters are very important at all times because there's always a risk of transmission of infections. And this was not that we are conscious of this only in the COVID era. Earlier also we have been using these filters because the person exhales his air into the spirometer. And if a filter is not there, there is a chance that the microbes may get into the machine, especially if it's a closed system. But a pneumatic based machine is, because it's an open system, the risk of infection is minimal. But still, these filters are used, and these are not very expensive. Then there are other requirements. You require a height measuring device, a stadiometer. You require weighing scales. Now, height and weight are useful and very mandatorily measured parameters because you require these to calculate prediction equations. So when the spirometer is started, the software screen, the first screen will ask for the patient's biographical details as well as height and weight. Then the room temperature has to be entered. The measurements in spirometry are expressed at body temperature saturated conditions. That is, we express these volumes at 37 degrees centigrade. Air expands on heating. If the ambient temperature is, let's say, 15 or 20, then the volume is smaller. But inside the body, it will be little larger. So the temperature correction is applied. That we have measured the volume at patient's ambient temperature in the room, and actually it is this much at 37. So whatever the temperature is there in the room, that is recorded, and a temperature correction factor is generated. Humidity is required because we do the measurements at fully saturated air, and then atmospheric pressure is measured. So all these are entered in the first screen of the spirometer. Now coming to the spirometry displays. Now this is an example of a volume time display. Now a spirometer measures several volumes and capacities. We are all familiar with the volumes and capacities. There are 4 volumes and 4 capacities. Now all volumes and capacity, of which residual volume is a component that is not measured on spirometer. So that means that residual volume, the functional residual capacity and total lung capacity, these are not measured on spirometer. Other volumes and capacities can be measured on spirometry. So the maneuver starts like this, that initially the patient does tidal breathing, that is breathe in and out the tidal volume, which is about 500 ml. Then we ask the person to take a deep breath in as much as the person can breathe in. So that means that he reaches the point of total lung capacity. From that point, immediately the person is asked to exhale out with full force, as much force as he can apply, and go on breathing out, go on emptying the lungs till no more air comes out. That means the patient reaches the point of residual volume. So the volume exhaled from total lung capacity to residual volume is called the forced vital capacity, or the FVC. When the patient starts this maneuver, we start the timer. So the start of the expiration is taken as time 0. And at the end of the first second of expiration, the volume that comes out is measured. So this volume is called as FEV1, or forced expiratory volume in the first second. And the slope of this expiratory curve, this is the average of the flow rates over the middle 50% of the vital capacity, called the FEF 2575, or force expiratory flow in the mid range of the vital capacity. There was a time when this was supposed to indicate small airways obstruction, but over time we have realized that there is too much of variability and it is not a specific test for small airways function. So it is no longer used that way. So here we see it's a volume versus time, that this axis is showing the volume and this is showing the time. So this is a classical volume time display of spirometry. And this is the flow volume curve. Now it looks entirely different, although the maneuver is same. The classical shape of a flow volume curve is a triangle over a half circle. Now this is the zero line and the flow rates are on the y-axis and the volume is on the x-axis. Now the flow rate in the upper part of the line, these are the expiratory flow rates, and below the line is the inspiratory part. So let's look at the maneuver first. Like tidal breathing, so patient after tidal breathing takes a deep breath in and reaches the total lung capacity. From that point, immediately the patient breathes out with maximal force. When the patient has reached total lung capacity, then the airflow stops, that is, no more air is coming out, so flow is zero. Immediately as the patient exhales out, because the lungs are fully, they are filled up with air and the airways are maximally dilated, so immediately there is a rush of air and the flow rate becomes very fast. So the highest flow rate which is achieved during expiration is called peak expiratory flow rate. As the person goes on breathing out, the airways become smaller, so the flow rates start falling. And at each point in exhalation, we can measure the flow rate. So when the 25% part of the vital capacity has been exhaled out, the flow rate measured is FEF 25. 50% exhaled out, it is FEF 50. 75% exhaled out is FEF 75. And when the person completes his expiration, comes to the residual volume, the flow falls to zero. So on the x-axis, we are measuring the vital capacity. So patient starts from here and goes on breathing out, and these are different flow rates which are achieved as the expiration proceeds. So we start from zero flow at TLC and reach zero flow here. So the volume exhaled out from total lung capacity to residual volume is force vital capacity. Now in this curve, notice that there is no time axis, and FE1 is a very, very useful parameter in lung physiology. So the computer runs a timer in the background and it marks time ticks on the x-axis. So the volume that has come out, so this is the total vital capacity. So this has taken about 4 to 5 seconds. Out of this, the volume that comes out in the first second, which will be identified by a small tick. So this is FEV1. On the inspiratory side, again, we have got similar flow rates, FIF 25, 50, 75. So these are inspiratory flow rates, these are expiratory flow rates. In general, in lung function testing in spirometry, it's mostly the expiratory flow rates which are important. Now, this important physiological point here to know is that the first 1/3 of the expiratory flow volume curve is effort dependent. That is, if the patient's efforts are not uniform or reproducible, then the peaks can differ. But the latter 2/3 is reproducible. So irrespective of the patient's effort, the curves will fall along the same line in the latter part of the curve. So that makes it very, very reproducible. So these are the different parameters that we measure. Now in a flow volume curve, it is very important to remember in quality control that there are three main regions. One is the start of the test, one is the peak of the test, and one is the end of the test. When we talk of what is good spirometry, then we have to make sure that the start is good, peak is good, and end is good, and there are no artifacts. So both volume flow and volume time graphs are complementary, and in modern machines you can get both the displays from the same maneuver simultaneously in real time. The flow volume is more informative to pick up the correct start of the test, peak, and the middle part for artifacts. And the shape of the flow volume curve provides important clues to pathology because the shape changes with the obstructive pathology or the restrictive pathology. So one can get some impression from the visual inspection of the flow volume curve as to what kind of pathology the patient may be having. The end of test, on the other hand, is picked up better on a volume time curve. So both tracings are complementary and both should be obtained. So a good machine is one which gives you both the displays, both in printout as well as on the screen. The scaling of axes is important, and the standard scale is that per division on the flow axis it should be 2 liters per second, and on the volume axis it should be 1 liter per division. So what are the indications for spirometry when you may be asked to do spirometry? As a diagnostic tool when the patient has symptoms or signs, or an abnormal lung function, abnormal laboratory test, or an abnormal chest X-ray to establish what kind of disease the patient may be having. Then the functional assessment of the impact of disease, that the patient has a disease, then what is the impact on the patient's performance, the functional or the physiological impairment. For example, in gold, we use it to do staging of COPD. Then as a screening tool for individuals who are at risk of having pulmonary diseases, for example, smokers, or those who are in occupations where exposures can lead to lung diseases. Then assessment of response to therapeutic interventions. This is a very useful indication, and we do spirometry as often as required to find out whether the patient is responding to treatments, whether we have to step up or step down. Then the natural history of disease. There are many diseases like COPD or the wide spectrum of interstitial lung diseases which have a poor one-way downhill course. So at what rate the patient is deteriorating and whether we have to change our approach and management, that clue is obtained by serial spirometry. Then as a tool for preoperative assessment, especially if the patient is undergoing the thoracic surgery or upper abdominal surgery, then what are the risks of post-operative pulmonary complications. Very often our surgeon and anesthesia colleagues ask for preoperative fitness. So we have different kinds of risk stratification scores. We don't say fit or unfit, we only say it's a high risk, medium risk. So risk is stratified based on patients' PFT and other performance indicators. Then to assess the prognosis, whether the patient is going to benefit from an intervention like lung transplantation. Monitoring of persons who are engaged in occupation with exposure to injurious agents. Some of the drugs like abdominal chemotherapy may injure lungs and cause lung fibrosis. So to pick up the lung damage before it's too extensive. Then lung function testing is required for insurance purpose, for rehabilitation, for legal reasons. For example, when there was the Bhopal gas exposure, then this was done in a very big way in the whole community to assess what is the residual damage because of the gas exposure. Then in surveys, for example, you want to study the effect of air pollution on lung health or effect of indoor pollution on lung health. Then derivation of reference equations requires spirometry. So there is a large range of indications when spirometry can be done. There are few contraindications, and these are relative contraindications when you would postpone spirometry, that is not go ahead with spirometry. So the person who is referring the patient for spirometry, he should know whether the patient has any kind of contraindication. So usually these contraindications are relative and not absolute. Once the patient recovers, then we can do the test. So a very ill or breathless patient, here firstly the patient will not be able to cooperate during the test, and secondly stabilization of the patient is more important than doing a spirometry. Hemoptysis of unknown origin. Here again the objective is to find out the cause of hemoptysis rather than to do a functional assessment of the patient. Pneumothorax again requires emergency treatment, so one would not think of a spirometry. Patient having unstable cardiovascular status. So these are medical emergencies where the patient has to be stabilized. A known thoracic, abdominal, cerebral aneurysm if the history is there. A recent chest wall trauma or patient is in pain because maneuver requires a good understanding and effort, and patient who is in pain will not be able to do it. And eye surgery, especially when it was eye surgery with stitches in the olden days, then this was a contraindication for almost up to 8 weeks. But now stitchless surgery is being done, so that period has been shortened. But still, it is prudent not to do spirometry for at least 4 weeks after eye surgery. Any acute process which interferes with patient's performance, for example, the patient is having abdominal pain or vomiting, obviously the test will be postponed. Any recent surgery of thorax or abdomen. So these are the relative contraindications. Once the patient has recovered, then the test can be done later. Then how do we prepare the patient? The patient is allowed to take a light meal, and he is instructed not to wear any tight clothing around the neck, for example, a collared shirt with buttons on or a tie. On the day of the test, generally the patient is asked not to do any exercise because vigorous exercise can change lung function. Smoking alters lung function. So ideally, nobody should ever smoke, and certainly not on the day of the test. Now, drug withdrawal requires a consideration. When the test is being done for the first time and one is working up, for example, a patient with suspected obstructive airways disease, then knowing what is the response to bronchodilator is part of the test. So it's the physician's decision. If the patient has been on treatment and then one wants to know what is the patient's best level on treatment, then the patient can be asked to take his bronchodilator and come. So first time assessment generally would require drug withdrawal, and usually it is 12 hours withdrawal. So overnight, if the patient is stable, he is asked not to take. If the patient is on inhaled steroids, then he can take those. So we need not discontinue inhaled corticosteroids. So performance, again to repeat, after the calibration, noting temperature and time and pressure, patient's details, whether the correct patient is taken up, height and weight are measured, and these are entered in the first screen of the computer. Infection control, a filter has to be used, and in today's era, one has to be very careful in doing a lung function test. We have started doing spirometry after taking due precautions. So our technicians are using personal protective equipment, and we make sure that the patient does not have an active COVID infection. So patient is given a hand wash, the technician uses a hand wash, mask, gloves, and lab coats. These are very important measures which one must take during the operation of the lab. So there are 4 distinct phases of the maneuver. One is the maximum inspiration, that is as fast as possible. A blast of expiration without any pause. So you take a maximal inspiration and reach total lung capacity. Immediately blow out without any pause. Complete the expiration forcefully for a maximum of 15 seconds. Beyond that, very little air comes out, and because expiration builds up a positive pressure, the patient may topple over or have a syncope. So generally we don't force the patient to go beyond 15 seconds. And this time can be monitored on the computer screen. And then finally, inspiration at maximum flow back to the maximum lung volume. So inspiration, expiration, forceful expiration, and again maximum inspiration. So all the efforts are complete as well as fast as possible. So this is the mantra of spirometry, that the maneuver must be done properly. The test is explained to the patient, the maneuver is explained, and generally what we do is that we let a patient watch the previous patient so that he gets a live demonstration of how the test is done. The test is done with the technician encouraging the patient to perform as forcefully and as fast as possible and as completely. So encouragement during the test is very important. So this is one role which technicians in other tests do not have to perform. For example, an EC technician need not say anything. A person doing echo need not say anything. But during spirometry, almost the technician has to shout. And sometimes patients complain that your technician is very rude. But a good technician, simply by shouting, encouraging the patient, can get an 100 or 200 ml extra from the screen. And when we are doing the test, we must watch the patient, because the test builds a positive intrathoracic pressure and patient can get dizziness or topple over. The screen has to be monitored at the same time to see the procedure for quality control, whether we have to accept or reject the maneuver. So the test is done in a sitting position, although people have described spirometry in other position, but that is for specific purposes. Usually it will be done on a chair with arms and no wheels. This is very important. Loose collar, mouthpiece, clip, how these are to be fitted properly. Then the 4 phases of inspiration, expiration, explained. So maximum and as fast as possible. Now, having done the test, the next step is to give a comment on whether the maneuver is acceptable or not. Acceptable means whether the patient has done it as he should or there is a need to repeat it. Normally, we do the test 3 to 5 times, and objective is to get 3 acceptable tracings. So these acceptable tracings have been defined, and in different standardization statement there have been minor changes in the acceptability criteria. So the current criteria is that the start of the test. In one of the earlier slides in the flow volume curve, I had stressed that there are 3 important points to look for. One is the start to the test, that is when the patient has reached the total lung capacity. So immediately from that point, the patient must exhale out full. If the patient has slight hesitation at total lung capacity, there is a small leakage of air. So that is measured by a process called back extrapolation. This is measured by the software, and usually this will display in the results that patient's back extrapolated volume is how much. So the acceptable back extrapolated volume is 5% of the vital capacity or 100 ml, which means that the initial hesitation led to loss of this much of volume. So this will be removed from the vital capacity. There should be a quick rise and a sharp peak. There should not be any coughing or glottic closure, and there should not be any leak in the equipment or from the mouthpiece. So these an experienced technician can make out by looking at the tracing. Then the end of the test must be satisfactory. This is the end of the force expiration. So either there is a plateau, that is a volume change less than 25 ml in the volume time curve for last 1 second, and expiry time more than 15 seconds. Earlier there was a time limit of at least 6 seconds that has been removed in the ATS 2019 statement. The inspired vital capacity and expired vital capacity should be nearly similar, but the difference should be less than 100 ml. And the earlier requirement of 6 seconds FET has now been removed. So there should be no volume change at the end of the expression. This is the most important point, and expression should not go for more than 15 seconds. So when the hesitation is too much, that is the back extrapolation volume is 100 ml or 5% of vital capacity or more, the peak is not there, there is coughing, early termination, leak around the mouthpiece, obstruction by tongue, then the test is rejected and the patient is asked to do it again. Now, how do we recognize all these? This is through a careful inspection of the display on the screen. Now, let us take these by illustrations. Now, this is the back extrapolation. Now, look at this example. The patient has inhaled and reached the total lung capacity. From that point, there is a slight hesitation, that is, the patient's effort is not maximal. Yes, there's slight leakage of air, and then the patient applies maximum force. So the sharp rise in flow rates is there. Now this much volume has taken some time. So if this is measured, then the volumes measured will be erroneous. So what is done is that we drop a vertical here to the x-axis, and then take this as the starting. This is the assumed start. So this volume, this is deleted or subtracted from the force vital capacity if this is less than 100 ml, because that does not materially alter the results. So this is back extrapolation volume, and the software will tell you that in this effort, the back extrapolation volume was 100 ml or more. So if it is 100 ml or less or 5% of the total vital capacity, then we say that we are okay with this and we accept the effort. Otherwise, this is rejected. So these are the 3 points where focus is there in quality control. The start has to be without hesitation. There should be a sharp peak and a smooth termination. So this is an acceptable curve, and our effort is to obtain 3 such acceptable curves, which some patients, those who are trained, have done it repeatedly. They simply come and give the 3 blows. Those who are doing for the first time may require coaching and may require 5 or 7 efforts. Beyond 8, generally the test is postponed because it's a tiring maneuver for the patient. So these are the 3 areas where the technician has to monitor, and this display is actually seen in real time on the monitoring screen. Now these are some of the examples of poor efforts. Now in this example, obviously there's a slow start, then peak. So this is clearly not acceptable. It's submaximal or hesitating performance. In fact, it's very common to see this kind of effort in a patient who is doing it for the first time. But this curve, there's a quick rise. The start is without any hesitation. So good start, good peak. And then we find that as the patient is exhaling out, suddenly the flow rate falls down to 0. If we extrapolate it like this, the flow should have gone like this. But either the tongue has obstructed or there is a closure of the larynx, adduction of the vocal cords. So suddenly the flow rate comes down to 0. So the actual vital capacity should have been till here, but now the measured vital capacity is only this much. So this sudden termination, which I showed in the last slide, is obstruction by tongue or laryngeal closure. This is not acceptable. Now this is a good effort. Now I mentioned about the force inspiratory vital capacity. Although we don't use FIVC in general in most of the interpretations, but as a quality control this is important. And the difference between the force vital capacity and the force inspiratory vital capacity. See, force vital capacity expiratory is TLC to RV, and inspiratory is from RV to total lung capacity. So here, after the maneuver, the patient has taken a deep breath in. So this difference should not be more than 100 ml. This maneuver shows these sawtooth serrations here. So this is cough during the maneuver. So this is not acceptable. So if the technician finds that patient has these, a couple of coughs occasional may be ignored, but if these are large swings, then this will affect the measurements. So this is a perfect curve. This kind of curve where the terminal decline is fast is seen in young persons. So this is different from obstruction or laryngeal closure. There the flow will immediately fall down vertically. Here it is not falling down vertically, but still there is a slope. So this is okay. Now this is obviously a poor effort, that the patient's peak is much less than what it should be because the patient has not exhaled out with maximum force. And as we know, the first 1/3 of the effort is effort dependent. So here the maximum loss is not there, so we will reject this. Now some patients, they stop in between, again restart. So this again is not acceptable. A knee, this kind of bend in the early part of the curve may sometimes be observed in young patients. So this is acceptable. Coughing during the maneuver, couple of coughs is okay, but large swings are not acceptable. So whenever on screen we find these kind of mistakes, then we do the test again. Having obtained 3 acceptable criteria, that is 3 curves with this kind of appearance, then we have to see whether the patient's efforts are reproducible. So that means the patient's efforts, they should not differ. So the next largest FBC and FE1 should not be different by more than 150 ml. So we go on doing the test maximum 8 times till we get 2 curves where the FBC and the FE1 are not different by more than 150 ml. For pediatrics, the limit is 100 ml. Then there is a grading system for spirometry. So if the repeatability is met to the described limit and 3 curves are there, then we say it's a A grade spirometry. If 2 acceptable are there and repeatability is good, it is B grade. So likewise, F is clearly not acceptable. So this is an objective way of grading the quality of the effort. We may get some useful information in curves which are C or D grade, but generally these are not accepted for interpretation, especially when the patient is doing it for the first time. So quality control is very important, and if it is not done properly, either the maintenance of the equipment or the performance of the test, then we get poor results. Then how do we report the results? We take the curve where the sum of the FVC and FE1 is the highest. Among all the acceptable tracings which have passed the repeatability criteria, we add up FVC and FEV1. The loop which gives the highest sum, that is taken as the patient's best result, and that is printed for interpretation. Generally in interpretation we take only 4 parameters: FVC, FE1, the ratio, and peak expected flow rate. In most printouts one would get 15 or 20 parameters. These are derived parameters and are generally of very little application. So the interpretation of spirometry is based on these 4 parameters. In interpretation, firstly we look at the flow volume curve and then consider these parameters. The peak expiratory flow rate is useful as a quality control tool. Otherwise, the actual interpretation is based on FVC, FE1, and the ratio and the shape of the flow volume curve. So we compare the results with predicted values. Then we compare the pattern with what we know about patterns in other diseases. For example, is it an obstructive pattern or is it a restrictive pattern? And then we compare the test with the patient's previous value. So 3 kinds of comparisons are involved in interpretation. Then the clinical data has to be considered, the patient's imaging features, the pre-test probability of the diagnosis, and then if the results suggest the need for a further testing, this is advised. Because lung function testing is a very vast topic, and spirometry only gives the clue to the pattern of disease. Except for COPD, it is not used as a diagnostic test for any lung disease. It tells you about the pattern of the abnormality, whether it's obstructive or restrictive, and what is the degree of impairment. So pre-test probability is very important, especially when the results are borderline. So lung function assessment interpretation is always in conjunction with the clinical data of the patient. Now, what about the normal values? See, for all biological measurements, we need a normal value to say whether the patient's measured values are in the normal range or they are abnormal. In lung function testing, we do not have fixed normal values. The normal values, these vary with patient's race, this is ethnic variation, height, age, and gender. So that means that all persons will have different normal or what are known as predicted values based on these parameters. So that is why these parameters are entered when spirometry is done. And we match the patient's values with a population which has similar parameters. So this is obtained from prediction equations. So we must use equations which match the patient's ethnic background, and they apply to patient's range as well. We must use local equations because there is a substantial chance of misclassification when Western equations are used, because Caucasian values are larger than Indian values, and even within different regions in India we have found that there are regional differences. So ideally you should have your own equations for your region. They should be current equations developed as per the current standardization protocols, because the equations developed earlier, and we have several equations from different regions in India developed 30 or 40 years ago, which may not be valid. A good software will allow you to feed in your own equations. So when you go in for purchase of equipment, this must be checked whether you can put in your own equations or not. Till a few years back, we did not have Indian equations, but based on the 2005 standardization, we carried out major projects both in children and adults in different regions of India, and now we have equations as per the current protocols, and these equations are now available in different equipments right from the manufacturers. The original softwares that one gets with different manufacturers, they are being fed with these equations. So these equations take this format. For example, this is our equation for North Indian adults, So the forced vital capacity is equal to as given in this expression. So all you need to do is to feed in patient's age, height and weight and you get the predicted value. Now this is only the predicted value. So this is the 50th percentile. To calculate the range of normal, you require another parameter which is called standard error of estimate. Because lung function testing, even in 100 people of same age, height and weight will not be exactly same. There will be a range of normal value. So that dispersion of that normal range is given by standard error of estimate, and this is given in the equation. In spirometers which don't have Indian equation, sometimes a correction formula is given like occasion into 0.9 is equal to an Indian value, but this is wrong and one should not go in for these kind of corrections because there is a lot of over and underestimation of abnormality when these corrections are used. So these are not recommended. Then what is abnormal? See, values less than lower limit of normal are abnormal, clearly. And in spirometry, there are no upper limits of abnormal. As a rule of thumb, sometimes values which are over 80% of the predicted are taken as normal. But this can be wrong, especially at the extremes of ages and the age range. And the gold criteria, for example, is another example of fixed level. So this can lead to overdiagnosis in the elderly. So ideal lower limit of normal is predicted minus the product of 1.645 into standard error of estimate. So this standard error of estimate, as I've shown in the previous slides, is available in the equation. So 1.645 into 0.479, we subtract from this expression and that gives us the lower limit of normal. So if the patient's measured value is less than this, then we say that it is abnormal. All other approximations can give you error. So this is the correct way of saying what is the lower limit of normal. And there is no upper limit of normal in spirometry. But there are upper limits of normal in diffusion capacity and in total lung capacity. Then interpretation. So we look at FE1 by FVC ratio first. If it is less than lower limit of normal, that defines airways obstruction. So by definition, airways obstruction is an FE1 by FVC ratio less than lower limit of normal. When obstruction is there, then we look at FVC. There are two situations possible here. One, the FVC is reduced with obstruction. Now this can happen either when there is a mixed disorder, that is that there is an airway obstruction as well as a parenchymal defect, or there is air trapping, that is severe asthma or emphysema. So that can also reduce forced vital capacity. Or if FVC is normal, then this is pure obstruction, that is the ratio is reduced and FVC is normal. So here to say whether it is air trapping or a mixed disorder, one needs to do lung volume estimation. But here the purpose is solved, that it is pure obstruction. If the FE1 by FVC ratio is more than lower limit of normal, then we say that there is no obstruction. So FE1 by FVC ratio defines the presence or absence of obstruction, whether it is less than lower limit of normal or more than lower limit of normal obtained from the prediction equation. So when there is no obstruction and FVC is normal, then we say that it is a normal spirometry. And it is entirely possible that a person can have a normal spirometry, but other tests may be abnormal. So it is not the patient is normal, only spirometry is normal. And if in the absence of obstruction, FVC is reduced, then we give a comment that is suggestive of restriction and the patient requires measurement of lung volumes or correlation with the clinical features. So on spirometry, we get patterns. There is normal spirometry, there is obstructive pattern, there is pattern of reduced vital capacity, which requires further testing. This is suggestive restriction. Obstruction with reduced vital capacity, and then certain patterns of large and small airways disease, which is beyond the scope of today's lecture, so I'll just be touching on these. So this is what we identify by applying this algorithm. So these are some of the examples of obstructive and restrictive patterns, and this is the advantage of a flow volume group. See, in this curve, there is a concavity here. So this concavity is very characteristic of an obstructive pattern. On the other hand, a restrictive pattern will have a quick rise and a quick fall. Now this concavity is very much evident on a flow volume loop, but this is very difficult to pick up on a volume time basis. So volume time tracing is good for end of test, where you will see a plateau as a flat line. Picking up end of test can be a little difficult in the flow volume curve. Start of test, peak of test is difficult to pick up here. End of test is easily picked up here. So shape tells you about the pattern of abnormality and the quality control in flow volume. Having done spirometry, then if it's an obstructive pattern, then we can classify the severity of airways obstruction based on FE1 expressed as a percentage of predicted. Now, this is different from GINA and GOLD categories of staging and severity assessment. So this is when we don't have the clinical diagnosis and we have done a spirometry, got an obstructive pattern, and then to say that how much is the severity of airways obstruction. After we have documented obstruction, then a bronchodilator is given. We give 200 to 400 micrograms of salbutamol through a meter dose inhaler. An increase in FVC or FE1 of 12% or more means that it's a good bronchodilator response. Most asthmatics will show a positive response and most patients with COPD will have a negative response, but that is not absolute. So reversibility test is no longer used as a diagnostic criteria to differentiate asthma from COPD. So these are some of the examples of obstructive pattern. The loop is opening up after bronchodilators. So visually one can say that after bronchodilator there is an improvement or there is a bronchodilator response. Here the loop pre and post bronchodilator has come virtually along the same path. So there is no bronchodilator response. And a word about the extrathoracic obstructions. Here the shape of the loop changes. For example, in variable extrathoracic obstruction, the inspirated loop is flattened. Then in fixed obstruction, it's a box kind of rectangular box where both inspiratory and expiratory loops are flattened. So that clue one can get from inspection of the inspiratory part. A couple of examples here. So the FE1 by FVC ratio is reduced. After bronchodilator, the FE1 has improved. So the FE1 here was 64% of predicted. So FE1 by FVC ratio is reduced and the FE1 is reduced. So this is obstruction which is showing reversibility. Now this is another case where the FE1 by FVC ratio is in the normal range and the FVC is reduced. So this would suggest a restrictive pattern. So this is a case of interstitial lung disease. So finally, the limitations of spirometry. The test results are not disease specific, except for COPD, where we use post-bronchodilator values to say whether patient has got COPD or not. There is no criteria for diagnosis of any other lung disease. We only get information on patterns and the functional impairment. A spirometry may not be sensitive enough to show early abnormalities, and it is very well known that patients can have a diseased lung with normal spirometry. So early emphysema, early interstitial lung disease will have normal spirometry. There is a very wide range of normal values, and single tests may be difficult to interpret. Serial tests that way are more informative. Values which are borderline, these may be difficult to interpret, and one must look at the clinical data. For example, just above the lower limit of normal may be found in a patient who has a very early disease, and just below the lower limit of normal value may be found in a person who is entirely normal. So clinical correlation is required before we label a patient as having a normal or an abnormal lung function. Further testing should be advised if picture is not clear. And finally, quality control is very important. If quality control is not exercised, then data obtained is very, very misleading. So I thank you very much for your presence. And if there are questions, then I'll be glad to answer those. Thank you.
Good evening, one and all. Shabra sir, it was an excellent session, very detailedly covered, and numerous questions were poured in. It's can we go for question and answer, sir?
Yeah, sure.
Yeah. So here, your comments on in a cardiac patients, particularly, okay, this question is from Dr. Preetham. How soon can a PFT be in cardiac patient, especially after a acute coronary event?
There are many cardiac patients who have a coexistent lung disease also. Now, it is important that the patient's coronary status becomes stabilized. So if there are any arrhythmias or alteration in blood pressure and he's feeling weak, then obviously is not the right candidate to take up for lung function test. So it will vary from patient to patient depending on what is the extent of damage the patient had. Right. The patient, so that is why these patients are rapidly rehabilitated, and once they have recovered, so usually at 8 weeks, patients have recovered sufficiently well, and we can do lung function tests.
On probably 6 to 8 weeks.
6 to 8 weeks. Yeah.
6 to 8 weeks. But on the top of it, overall performance status of the patient.
Exactly.
And there's,
got a very severe MI ejection fraction down to 15-20%, always breathless. So there can be a problem in those patients.
Yes.
It's individualized, but 6 to 8 weeks is average.
Here is a question which is asking us how to maintain quality of spirometry consistently in our labs. And do you see that, there is a difference between the older generation spirometry missions and the newer generation ones?
See, the quality control is something which you can never dispense with. It is daily exercise. The technician has to do his role, and the person who is in charge of the lab, he has to do his role. So that is mandatory. I mean, there's no other way. If you don't do spirometry properly, might not as well do it. The other thing about spirometers, with newer technology, things have become easier, but accuracy has been maintained, and that is the whole purpose of standardization. So we have periodically statements from ATS and ERS where the technical specifications are laid out, and these are rigorously checked. So all manufacturers, they give a certificate that the equipment performs as per requirements. So with time, the newer softwares and equipments have become easier to handle, more user friendly, but they have not lost on their accuracy. In fact, these are easier to maintain now.
It's like, our pulmonology colleagues, okay, before performing bronchoscopy, they should know, what is the basics of bronchoscopy, what does the equipment contains, and how to wash it, how to sterilize it, everything we have to know. Similarly, how to maintain spirometer is most important. Right, Nasir?
Yes, absolutely.
So, one of your slides clearly mentioned that it can help in assessment of cardiac dysfunction. Please enlighten us, sir.
It may come as a surprise, but spirometry was first used in cardiac patients, not in pulmonary patients. Now, isn't that surprising? The word vital comes from the word life, and it was used as a prognostic indicator in patients who have got a cardiac disease. So that was the first application of spirometry. Now, it has been very well shown in epidemiological studies that smaller the vital capacity, lower is your life expectancy, and one is likely to have a cardiac event earlier. In patients who have got active cardiac disease, because of increase in left atrial pressure and pulmonary congestion, there is submucosal edema. So these patients develop features of airways obstruction. In fact, a patient with cardiac failure can wheeze because of this, because there is airway narrowing, and this responds to diuretics. So on spirometry, we can pick up small airways obstruction through the concavity, and depending on the extent, it will be, the degree will vary. Plus there is parenchymal congestion also, so vital capacity also reduces. So very often we get a mixed pattern in cardiac failure. And this can be used as a tool to monitor patients' response to treatment. With good treatment, it improves. So it's very valuable in lung function, cardiac patients also.
Here, Dr. Fazli Kibriya Chowdhury, he has asked, it was very informative, sir. Can you please elaborate more detail artifact identification in spirometry?
Well, the artifacts, these pertain to different regions which were highlighted in my slides. One is the start of test, one is the peak of test, and one is the end of test. And then the falling limb of the curve. The start of test, the main problem there is a slow hesitancy which leads to a small leakage. So there you require back extrapolation. The procedure was explained, and these days the software will do it for you and tell you that this is the extent of correction that they have done. Absence of a peak means patient's effort is submaximal. A termination which is not smoothly going down to zero but suddenly stops and falls to zero is an artifact. Cough producing a sawtooth appearance is an artifact. So these are different kinds of artifacts which are picked up, and that is a technician's duty to monitor it on the screen. So your screen should be large enough and show the flow volume curve as well as the volume time curve in real time. So you actually see the procedure being performed, and there itself, rather than store it and then delete it, there's an escape option that you don't want to record this. So you immediately press that and do away with that.
So if the cough is in initial half, okay, I think, we can still accept this as a good quality spirometry.
Cough immediately after total lung capacity, that sometimes produces very high peak expiratory flow rates. So that is not physiological. But later on, a couple of coughs, especially towards the end of the effort, those are acceptable.
This what we commonly see in our practice. Towards, in the later half, patient starts to cough.
Yes. So those small coughs are acceptable.
Right. So here, Dr. Sunita is asking about when the post bronchodilator values are less than previous values, what should be the inference?
I didn't get the audio got interrupted. Again,
so when the post bronchodilator values are less than previous values, what should be the inference?
This can happen, and this is a very good question. Firstly, it may mean that the patient is tiring out. That is one. Second, in patients who have got severe asthma, sometimes we find that with each progressive effort, the values keep declining. So patient's effort and its reproducibility as well as a physiological impact of the deep inspiration, which happens in severe asthmatics. So one can actually see post-bronchodilator values being lower than pre-bronchodilator values. So if the technical factors are ruled out, then it generally indicates a very severe disease. But usually it is the technical factors which are important.
So if FV1 by FVC is not less than 0.7 and still the patient shows reversibility of or significant reversibility of FV1, how to interfere such a test, sir? Well,
we need to be sure that the patient's criteria of acceptability and repeatability are being fulfilled both in pre and post. Sometimes there is a learning effect. The patient is doing it for the first time, so his pre-bronchodilator test, he is only learning the maneuver, and after that he does it properly, so you get higher values. Then so that is a artifact to the patient. This is a learning experience. Second is that some patients have a response which is both a flow and volume response. So here both the vital capacity and the FV1 will increase. So the ratio remains normal. So we can have a true bronchodilator response with ratio remaining normal, or a learning effect which shows that the values are increasing.
with the COVID era setting in, okay, most of the PFT labs are almost closed, or very negligible amount of PFTs is being offered. Do you recommend, here again, the question from Dr. Preetham, do you recommend a nasopharyngeal swab testing of COVID PCR assay or any rapid antigen assay before performing a pulmonary function test?
This is a question which is very often asked, and the guidelines that we have, the ICMR guidelines, they do not address this. See, the first thing is that if a patient has clear symptoms of COVID, then lung function testing is not a priority at that stage. So clearly there is no need to do a lung function test when a patient is symptomatically and a proven COVID. The question arises in an unsuspected COVID, a person who is asymptomatic and you're not sure about his status. So here, that is why people are taking precautions that the numbers of tests being done are reduced so as to avoid an unsuspected COVID patient coming into the lab. Doing PFT in COVID times involves firstly protecting your atmosphere in the lab so that your contamination of solid surfaces and equipment is not there. You have to protect your technicians and you have to protect the patient. So strict precautions for infection control are necessary. That includes fogging at the start of the test, after each patient, and then at the end of the day. Personal protective equipment for the technicians, patients wearing masks and maintaining distance. So only when it is very essential to do a PFT, that it's going to change materially the patient's diagnosis and management, then, and patient is clearly not a case of COVID, then we do PFT maintaining all the precautions.
Right. As we are seeing,
COVID patient, it will not be required.
Right. Say, as we are seeing, sequel of COVID right now, like, a lot of, interstitial infiltrates, parenchymal opacities, some amount of fibrosis establishing in these patients. Okay, how early we can start doing pulmonary function tests in these patients?
So this is a very important area which more and more information will come. I have been following up these patients and doing a CT at 1 month with lung function testing, and a small proportion of patients, not all. A lot of patients recover completely. That also I have seen. But some patients start developing extensive scarring. Disease starts resembling a diffuse parenchymal lung disease or an interstitial lung disease. Now these patients quite often are on oxygen, that they are not able to go off oxygen, or they are having a dyspnea of grade 2 or grade 3 depending on the extent of involvement. So this becomes a post-COVID sequelae. Now these patients have recovered from active infection. The COVID test is negative. So now these patients are not a risk to the community. So doing a PFT in these patients is not a problem. So at 1 month, that is our protocol, that we make the first assessment. And since only limited time period has passed since this disease has come, so as a protocol, what I intend doing is doing spirometry at 3 months and at 6 months to see whether the disease is a one-time damage, non-progressive, or whether it is progressing. So management will differ whether it's a progressive disease or it's a one-time damage. But 1 month after recovery, we can do a PFT in these patients. There's no risk to the technician or to the atmosphere.
Right. So Dr. Tridip Chatterjee is asking us, can a spirometry be done adequately in supine position? For example, a patient for preoperative assessment of fracture of leg bones.
Well, it is possible to do spirometry in a supine position, but there are limitations because the chest exertion is limited by the splinting of the back against the bed. So the vital capacity is reduced. So you are starting with a procedure which is not the standard procedure, and then you're ending up with a result which is less than optimum. So clearly it will be abnormal. So that value is not going to help in patient's assessment. Other tests like candle blowing or the ability to hold breath and do a count, those are more useful than doing a spirometry in a supine position in these patients. People have done this, but it's not of practical importance.
Similarly, in some cases like severe ascites and patients awaiting transplant, liver transplant, and some abdominal pathologies, your comments and guidances, please guide us how to perform a pre-op assessment for general anesthesia. This question is asked by Dr. Soumya from Hyderabad.
See, preoperative assessment involves an assessment as far as pulmonology is concerned to predict post-operative pulmonary complications like atelectasis, pneumonias, or a prolonged need for mechanical ventilation. Now, there are several standardized scores available which require consideration of patient's smoking status, pre-existent respiratory disease, duration of surgery, type of anesthesia. So these are put in the scoring systems and they give you the stratification that this patient has a high risk of post-operative complications, medium or low risk. Very few of the scores actually use lung function testing parameters for non-thoracic surgery. So it's only thoracic surgery that lung function testing has a bearing on the outcomes. So non-thoracic surgery, orthopedic surgery, abdominal surgery, laparoscopic surgery, here the lung function testing doesn't matter. In fact, smoking status is far more important. Lung disease which is there, that is far more important, preoperatively stabilization, and then perioperative assessment of the patients and taking care of the exacerbations. So lung function testing per se adds very little to the preoperative assessment in these patients. Multifactorial consideration for risk stratification. And we never use the term fit or unfit.
Right, sir.
That is very important.
Then here comes various colleagues are asking about a similar question, which I have framed it as if a patient of multi-drug resistant tuberculosis, or for that matter, any tuberculosis, needs a lobectomy or a lung surgery pneumonectomy. How do you evaluate, sir? How to go about? Do you suggest spirometry or not? One thing. Second, if at all spirometry is being, what precautions that we all need to take? Is there any role of using double filter?
See, patients who have got a vital capacity of less than 1.5 liters and diffusion capacity of less than 50%, they are at a very high risk of complications in a total pneumonectomy, and for lobectomy about 1 liter. So that is a limitation. So that predicts that the patient's survival is going to be affected. As far as taking precautions is concerned, generally this is done in hospitals which deal exclusively with tuberculosis patients. So they would keep one machine reserved for MDR patients. There also, all precautions need to be taken on the fumigation and fogging of the machine. Then the technicians who are doing the test, they have to use the PPE properly. In fact, the word PPE is now being used, but earlier the focus was not that much, and earlier also it was relevant that N95 masks must be used by the technicians who are in the PFT lab. And then cough etiquettes and hand washing, all they are very important. What we are learning from COVID era, they are very much relevant in the management of MDR TB also. So with these precautions, PFT can be done if there are no absolute contraindications. If the patient is very weak, having hemoptysis, then and having chest pain, the test will not be done.
Right. See, how many patients that a technician generally is allowed to handle in an hour? or in a shift kind of thing, sir?
Well, if the patient is coming for the first time and we require 3 acceptable tracing, the recommendation is that there should be about 5 minutes interval between the tests to allow the patient to recover from the effort. So pre-testing will be around 20 minutes. Then patient is given a bronchodilator and he waits for 20 minutes more. So in that second period of 20 minutes, we can take a second patient. So that way, the pre and post will be a sequence. So generally, a technician will be able to handle 3 patients in 1 hour.
Okay.
For good spirometry. If he is handling more, then both the patient and the technician, they'll become tired. So that will affect quality control. So ideally not more than 3 spirometries per hour.
Right. So here, Dr. Gayatri is asking about, is there presence of any active infection like COPD exacerbation is a contraindication for spirometry or tuberculosis? Okay. We discussed, but again, any active infection, is it really a contraindication for spirometry?
You see, when we do spirometry, then we're looking for information that will help in management. In a patient who has got an acute exacerbation of COPD, here the management is more based on assessment of respiratory failure and the patient's clinical condition. Patient is in distress. The required cooperation will not be there for the test. So lung function testing is not required in patients who come in acute exacerbations.
And Dr. Ajay is asking us, how the bronchodilator should be used? 200 microgram or 400 microgram? Is it 2 puffs or 4 puffs?
You see, when the patient is tested, then we test with an open mouth technique because the same MDI is used for different patients.
Yes.
There is always a risk of not going in optimally. So usually in therapeutics, 2 puffs are good enough, 200. But in testing, to take into account the loss, because a little bit of it may spray into the atmosphere. So it's better to give 4 puffs. And you can even nebulize a patient.
Right. Dr. Dinesh Raj is asking on us, please provide your valuable comments on mixed pattern, which is commonly seen in obese patients suffering from asthma.
Yes, see, obese patterns are real confounders. And obese mixed patterns we see in 2 kinds of scenarios. One, patients who have got severe air trapping. So there the vital capacity is reduced. Or patients who have got an added component of a restriction. For example, there is a parenchymal disease or they are obese. So differentiating these, the first thing is there obstruction or not? If the ratio is less than lower limit of normal, then that means that by definition airways obstruction is there. The second component you can sort out by doing lung volume estimation. If facility is not available, then a simple X-ray is good. If you see fibrosis or bronchiectasis, that would explain the mixed component that is there. If that is normal, but the patient has a very high BMI of 40, 45, right. So that will also explain that there is restriction. But presence of obstruction is necessary because after all, asthma is an obstructive airways disease. So the ratio must be reduced along with vital capacity reduction.
Right. So here comes an interesting question. Is presence of a intercostal tube drainage its contraindication? Okay, when we allow the patient to perform pulmonary function test.
If I may be allowed,
this is asked by Dr. Praveen.
If I may be allowed to ask a counter question, why would a PFT be required in a patient not an ICD?
Right.
Now, 2 issues here. The ICD may be for, let's say, an empyema or it may be for a pneumothorax. Now, pneumothorax, which requires an ICD, is an active pneumothorax. So clearly, it is a contraindication. So we wouldn't do because a lot of adverse effects can happen there. When the patient has an empyema, again, we know a factor that the fluid is going to lead to a restrictive pattern, and patient is in pain because of the tube. So both these would be contraindications for the test.
Right. So probably sometimes when we are posting a patient for mesothelioma surgery, okay, pre-op pulmonary function evaluation, sometimes patient may be coming with small ICD to drain. Those are the very rare scenarios where if pre-op evaluation for extrapleural pneumonectomy extrapleural pleurectomy, okay, can be offered. So maybe very rarely we may consider doing, sir. What do you say?
We are sure to get too many artifacts and suboptimal performance.
Yes, sir.
So that will confound interpretation.
Yeah.
I would rather go in for simpler bedside tests. They are two very important tests. Candle blowing and then counting. You hold your breath and how much can you count? If you can count to 40, you're good for general anesthesia.
Right. So one of my previous intervention pulmonology fellow, Dr. Kilima from Tanzania, she said it's an excellent session, Professor Chabra sir, indeed. Thank you so much. Conveying her wishes. Dinesh Raj has asked, Gayatri, Dr. Gayatri is repeat questions. Dr. Sandeep Salvi is asking about nowadays spirometry reports are mentioned with Z score. Sir, please explain.
Z score is a mathematically sophisticated way of telling us how much the values are away from the predicted values. You see, we talked about lower limit of normal. When we talk of the predicted value, then that is only the 50th percentile. And about 5th to 95th percentile, this is the normal range. So all patients within this range would be normal. So Z score is simply the number of standard deviations the value is away from the predicted value. Right? So
yes, sir.
One standard deviation, two standard deviations. So two standard deviations takes the value down to 2.5 percentile. So that is too low. So usually we say that 1.645 standard deviation, Z score, this is equal to lower limit of normal. So practically the same expression, like 1.645 into standard of estimate, which we use to subtract from the low limit of normal, that is LLN. So a value less than 1.645 Z scores is also below low limit of normal. So that is the modern way of reporting. So our current reports must include the predicted value. They must indicate the Z scores, the patient's observed values, so that one is able to understand. And this helps in, comparing patients. Supposing you've got 5 patients, all having values 2 Z scores below predicted value. So then we can say that all of them are at the same level of severity. Absolute values may be different, but there are 2 Z scores away from the predicted value. So they are of same severity. So that is the importance. It's a standardized way of comparing patients. Mathematically more complex, but not difficult.
Dr. Dayanand from Hyderabad is asking about spirometry pre-effort FE1 reading is greater than 80% predicted, yet post-effort shows greater than 13% increase in FE1. Still, do we consider it as a significant reversibility based on pre-effort?
Your voice got muted in between. Can you please repeat?
So, Dr. Dayanand is asking about, we have discussed this question, but again, Dr. Dayanand is asking about pre-effort FE1 reading.
Huh.
is greater than 80% predicted. Yet, post effort shows greater than 13% increase in FEV1. Still, do we consider it as a significant reversibility?
Yes, that is very common. See, again, referring to our predicted value as 50th percentile, it is
Sir.
by not it is by no means the upper limit. Some patients can have supranormal values. Their normal may be 120%, 130%. So for that person, 84-85% is a reduction in lung volume. So that person after bronchodilator can have sufficient increase and go beyond 100%. So it's very common to see patients who have a vital capacity of 120, 130%. So it is the other corollary of this is supposing a patient has symptoms and we find that the vital capacity is 85%, then it apparently looks as if it's normal. But we don't know what the patient's value was when he was healthy. Could have been 130%. So there is substantial fault, yet he is in the normal range.
This week we see quite common in our day-to-day practice, sir. So Dr. Mobin is asking us, Professor Chabra, sir, very nice class. Please upload this in any portal so that he wants to see again and again. We will do it, Dr. Mobin, definitely, and we will share the reference link soon in the CCI, all WhatsApp groups. Sir, your preference of impulse oscillometry or spirometry for evaluation of small airway disease?
See, personally, I have no experience of impulse oscillometry. Let me be very frank, because I have not been using impulse oscillometry. And impulse oscillometry is, like we have repurposed drugs. So it's a resurgence of intent. It's not a new technique. It has been there for 3 decades. Now, it is increasingly being used to explore the small airways, because there are some patients who may have a disease at small airways level, which may be based on spirometry, or there are very subtle clues like a terminal concavity, which help to tell us that there may be a small airways obstruction. But in spirometry, we really do not have any small airways parameters. So that way, impulse oscillometry should offer an advantage.
Right.
And more studies will establish that whether we are getting a validated parameter by which we can express small airways function. Otherwise, till today, and testing of small airways has been a big challenge. We used to have closing volume, we used to have frequency dependence of dynamic compliance. All these were either cumbersome or not validated. So that is area which is very much a black area which we have not been able to explore. So this may be one of the tools to do that.
So what is this bronchospirometry?
Pardon?
Is it of bronchospirometry?
Bronchospirometry?
Yeah. Is there any role in our day-to-day practice?
I couldn't get the question. You asked about
Bronchospirometry.
Bronchospirometry. See, bronchospirometry, it used to be done once upon a time, that I have read. I have never done it. See, bronchospirometry essentially means that you go into one of the airways and do a spirometry. So that would involve intubation and a very complex setup. So I'm not sure in what clinical circumstances one would be required to do it. Because there are other, and this was done when we did not have imaging techniques.
Yes.
Now you can do a CT scan and find out that that lung is normal.
Okay. Dr. Sweta is asking us, in a stable disease, name it either COPD or asthma or ILD, IPF. So how often do you recommend to repeat spirometry in each case?
Firstly, there are no hard and fast rules. It's all individualized, and a very important consideration is a cost consideration, because costs money, right? So if the management is going to change, then definitely spirometry should be done if symptom assessment is not allowed. For example, a patient's, let's say a case of asthma who says that he is well controlled, but on examination there are extensive wrong type. Or on the other hand, patient says that he's very symptomatic, but chest examination is clear. Then there's a problem of perception. So we require objective documentation. So this would be required. In asthmatics, after baseline, the next step is to establish the patient's personal best. So after intensive treatment, which would be usually 3 to 4 months, one lung function testing is required. Now this personal best is extremely important because for all subsequent future spirometries, this becomes the reference point. Because we know that this is the best the patient can achieve. Other diseases like COPD and ILD, in COPD, monitoring with lung function testing doesn't have too many practical applications because management is shifting more towards exacerbation and symptom assessment. ILD is important because in ILD, we have to decide a patient, let's say a case of steroid responsive ILD. We have to decide whether it is steroid responsive or not. So if the patient is not showing objective improvement by 6 months, then all we will do is produce adverse effects with steroids. This becomes a steroid non-responder and the patient has to be taken off steroids and tried some steroid sparing, or it's a progressive fibrosing disease and patient has to be listed for lung transplantation or taken up with antifibrotics. So following natural history of ILD is one very important application, and usually it is 3-1-3 that we do and define patient's responsiveness. If at the end of 1 year, patient is going down more than 10% fall in vital capacity, he is a non-responder to pharmacotherapy.
Sir, in the interest of time, okay, last few questions, maybe 2 or 3 we will take and then close the thing. There are many more questions to be answered, but I think, similar questions have been asked, we have discussed. Here comes on a broad scale, okay, how can we, give fitness for surgery based on PFT? Brief response, please, sir.
Question was touched. See,
firstly,
I have searched literature extensively. There is no word fitness or unfit used in literature. So it's only risk stratification. That how much is the risk when the surgery is done. So it's a high risk case, medium risk, or a low risk case. Secondly, in none of the standardized scores is PFT used alone. Many of the scores don't even use PFT. Right. So I would suggest that you go in and check the standardized scores because several patient related information is put in those scores and we calculate the risk of post-operative pulmonary function. So PFT is not the sole criteria and many times it is not the criteria to assess post-operative. And never use the word fitness.
Right.
Always risk stratification.
Is there any role of, are there any complications out of performing spirometry?
Yes. That is why the time limit of 15 seconds is there in the ATS 2019 standardization statement, because a forced expiration leads to positive intrathoracic pressure. That can cause reduction in cardiac output and patient can topple over.
Yes, sir.
Very rare a bout of cough can follow. Sometimes in a patient who has got severe osteoporosis or hip fracture can be. But these are extremely rare. Extremely rare. It's one of the safest investigations.
Again, the question from Dr. Sunil. Any role of spirometry in smoking cessation, whether we can motivate them or, what is your take on this, sir?
Yes, it is very important. If you are able to demonstrate that there is an impairment, nothing scares a person more than knowing that there is something actually wrong. So that motivates a person a lot. The other contra side of this is if it is normal, the patient may say that I am normal, not something. So one has to be careful.
I was supposed to ask the same thing. Yeah. So role of MVV in our day-to-day practice by Dr. Mohammad Munif.
Day-to-day practice, I would say it is obsolete. It was a test done many, many decades back to differentiate between obstructive and restrictive disease. But now there are other tools and it's a very tiring test, and patient can have respiratory alkalosis and giddiness. It's a voluntary hyperventilation, washes out CO2. It's a dangerous test to do.
Sir, in the interest of time, it's 9:40. Okay, with your permission, I want to wind up the session.
Thank you. It was excellently compared. Enjoyed it very much.
Thank you so much, sir. It was a brilliant session, one of the best sessions from the CCI webinars. I thank profusely for giving your valuable time despite your busy schedule. Of course, you have never said no to CCI whenever we want to involve you in CCI webinars and then academic events. And we will be looking forward for your meetings always in the upcoming CCI meetings.
My pleasure. Thank you so much.
Yeah. Thank you so much, CCI Core Committee group, our beloved chairman, Dr. N.H. Dr. Narayan Pradeep, Dr. Narendra, Dr. Ravi Doshi, Dr. Atri Gangopadhyaya. So all are really, working relentlessly to keep the standards of CCI webinars very high and flying. So that's why it's almost in this COVID era, we must thank COVID because, they are meeting virtually more frequently. And I can see huge enthusiasm. Today also, there were 1,000+ logins. It's amazing response, sir. And I thank all the core committee members. More importantly, our SIPLA people. Whenever we ask, they said they extended their unconditional support for supporting us to do these academic programs. And it's not an easy job. Thank you, Dr. Vipul, Dr. Puneet and team. And for the past 1.5 to 2 hours, close to 2 hours, we had a brilliant session. And with this session closing now, so looking forward for many more master classes. Next one, we are having, master class on chest radiology by our beloved senior colleague, Dr. Ravindra Babu sir. And then following which, many more, pulmonary thromboembolism. I profusely thank entire team. More importantly, 1,000+ colleagues watched this webinar for the past 2 hours. Okay. Thank you, one and all. Thank you. Good night.
Good night.
Good night, sir.